Hey everyone, I'm Silas, and welcome to Psilocybology. Let's expand our mind. This is a series where we take a deep dive into the research on psilocybin, the psychedelic prodrug found in magic mushrooms. We'll be breaking down and discussing the scientific literature, one study at a time, from past to present. Today's episode is on the article titled Comparison of Three Psychotropic Drugs, Psilocybin, JB329, and IT290, in volunteer subjects, published in 1960. The researchers of this study were interested in better understanding psychotomimetic drugs. Psychotomimetic drugs are those which produce a mental state that resembles psychosis, or a separation from reality. The three drugs they decided to examine were psilocybin, JB329, and IT290. Now, JB329 is also known as Digtran, and was developed during chemical weapons research. The goal with this research was to essentially develop non-lethal chemicals that could incapacitate their targets. JB329 works in part by blocking the actions of acetylcholine in the nervous system, which is a neurotransmitter that, among many other functions, has a prominent role in muscle movement. The researchers note, however, that although its anticholinergic activity explains how it acts on the peripheral nervous system, studies have shown that the blocking of acetylcholine is not what is responsible for its effects on the central nervous system. The other new drug that we'll be talking about is IT290, which is also called alpha-methyltryptamine. Unlike JB329, IT290 is a tryptamine compound, specifically an indole analog of amphetamine, so it is structurally similar to psilocybin. IT290, however, is classified as a psychedelic stimulant. Rather than being developed during the process of manufacturing chemical weapons, this drug was developed as an antidepressant and for a brief time marketed as Indepan in Russia. The methods of the study are a bit unclear, at least in terms of the administration of the three drugs across the different participants. There were 27 doses of psilocybin administered across 16 different subjects. There were also 11 doses of JB329 administered across 11 subjects, and 8 doses of IT290 administered across 8 subjects. Now, they note that 7 total subjects were given 1 dose of each drug, but that's all they mention in terms of participant overlap between the groups. It sounds like this study was mostly examining within subjects' effects, but partially examining between subjects' effects as well. When they get to the results, they don't disentangle their findings based on the participants, rather they just present the effects seen after being given each one of the drugs. The researchers were just as vague when it came to the doses they administered, providing only a range and no further description of the distribution of the doses. For psilocybin, they gave participants anywhere from 37 to 209 micrograms per kilogram body weight. For reference, that would mean someone weighing about 70 kilograms or 154 pounds would have been given between 2.6 and 14.2 milligrams of psilocybin. This is on the lower range. Often, modern clinical trials will use between 10 to 30 milligrams of psilocybin per 70 kilograms of body weight. For JB329, the doses ranged from 40 to 339 micrograms per kilogram, and for IT290, the doses ranged from 384 to 810 micrograms per kilogram. As for who the participants were, the researchers stated that they were mostly graduate students who had been, quote, trained to make objective observations and possess descriptive ability, who had also been screened for psychiatric disorders. First off, the fact that they said mostly graduate students makes me immediately question who the rest of the participants were. I would also have loved to know what the training was that was meant to improve the ability of the subjects to make objective observations. To touch on set and setting briefly, the study took place on a medical ward of a psychiatric hospital in a small and, quote, austerely furnished private room. Unlike in one of the previous episodes, where 4 clinicians were in the room together with the participants throughout the study, these participants were only infrequently visited by hospital personnel when obtaining clinical or laboratory data. The researchers divided the data they collected into 3 categories: clinical, biochemical, and psychometric. The clinical measures encompassed both self-report of their subjective experiences, as well as physiological measurements such as blood pressure, pulse, pupillary size, deep tendon reflexes, and coordination tests. For the self-report measures, the participants, and I thought this was very cool, were given tape recorders so that they could capture their subjective experiences. They were even given occasional time cues, so they were prompted to discuss what they were experiencing at consistent times throughout the duration of the experience. In addition to these recordings, they also completed a 43-question questionnaire that asked about the presence or absence of various symptoms associated with psychotomimetic drugs as well as psychopathology. The researchers then took this data and essentially mapped out the subjective experiences of each drug over time. Since our focus on this podcast is psilocybin, I'd like to go through the timeline for psilocybin in a bit of detail, and then contrast it with what they described for IT-290 and JB-329 at a higher level. So, within the first 30 minutes after being administered a variable low dose of psilocybin, participants reported feeling some dizziness, nausea, and abdominal discomfort. They also experienced muscle aches and weakness, shivering, anxiety, restlessness, and some numbness, likely the tingling sensation that we have come across previously. Between 30 and 60 minutes, participants began to report experiencing visual effects such as increased brightness, sharper outlines to objects, prolonged afterimages, and reported seeing visual patterns when their eyes were closed. This is also when participants began yawning, having decreased concentration and attention, and experienced depersonalization, or the feeling that you or your thoughts aren't real, or that you lost your self-identity. It's probably important to note that typically when experiencing depersonalization, people often retain their awareness that this is a feeling and not a reality. Typically those administered psilocybin experience distortions of reality, but not a total break from reality, and still remain oriented to the world. Getting back to the timeline, between 60 and 120 minutes after being given psilocybin, participants reported increased visual effects, that stationary surfaces appeared to be moving in a wave-like pattern, and a slowed perception of time. This is also when participants reported feeling euphoria and described themselves as being in a ruminative state, which is characterized by deep or considered thought. After 120 minutes, all of the symptoms mentioned began to subside, and after anywhere between 4 to 12 hours, participants returned to normal. Overall, the participants described the experience with psilocybin as, quote, pleasant and conductive to insights. Now, let's compare that to the experience after IT-290 and JB-329. And let's recall that IT-290 is a drug similar to psilocybin in that it is a tryptamine compound, and JB-329 is an anticholinergic drug originally designed to incapacitate those who took it. With IT-290, there were much weaker visual effects and much greater stimulatory effects such as jitteriness, restlessness, and anxiety compared to psilocybin. The effects also had a slower onset and a longer duration of action, often lasting between 16 and 18 hours, although they note that this might have been due to the larger dose administered for IT-290. The euphoria, however, was still very much present. It was described as a pleasant experience, though not as meaningful as with psilocybin. Unsurprisingly, the experience reported after being administered JB-329 was considerably different from either of the two other drugs. The participants experienced substantial mental confusion, which often manifested in such severe delirium that many participants were required to remain in the hospital overnight. Participants were disoriented, depressed, and described the experience as extremely unpleasant if they were able to even remember the experience at all. Getting back to the other data collected, all of the physiological assessments were taken before each drug, as well as 2 hours after taking psilocybin and IT-290, and 4 hours after taking JB-329. This discrepancy, where measurements were taken 2 hours after being given psilocybin and IT-290, and 4 hours after being given JB-329, is what they did for almost all of the remaining measures that we'll talk about. Although they don't state this explicitly, I assume, and again this is absolutely an assumption, that this was intentionally done because the peak effects of JB-329 might be reached after 4 hours, whereas we know the peak for psilocybin, and possibly IT-290, is about 2 hours. I spent a bit of time trying to confirm when the peak plasma concentration is reached after JB-329 administration, but there didn't appear to be a lot of readily available information on it that I could find. Regardless, with these physiological measures, they really didn't find much other than that all three drugs caused the pupils to dilate in almost all instances, and in a majority of cases, reflexes were increased. They noted very few instances where there were increases in blood pressure or pulse after being given either of the drugs, although they note that the few cases where an increase was found, it was associated with higher doses of the given drug. Similar null results were found for most of their biochemical measures, which included fasting eosinophil count, serum cholesterol, alkaline phosphatase and cholinesterase activity, serum glutamic oxaloacetic transaminase titer, and urine creatine levels. If we recall from last week's episode, alkaline phosphatase is the enzyme that dephosphorylates psilocybin into psilocin before it gets further broken down by monoamine oxidase. Out of the biochemical measures, they only found two differences. First, that psilocybin caused a statistically significant decrease in urine creatinine levels, which I found interesting because I was also recently reading more about how drug testing works, and low urine creatinine levels are used to detect when people are attempting to dilute the sample they provide, most often through increased water intake. Second, that psilocybin decreased eosinophil count, which are a type of white blood cells that fight parasites and certain infections. Notably, high levels of eosinophils are associated with tissue damage and asthma. After reading that, I'm really curious if anyone with asthma has ever experienced any alleviation of symptoms in response to psilocybin. The last of the primary measures were the psychometric tests, which included simple arithmetic problems, some drawing exercises where they had to copy images, and tests that involved participants needing to guess when 5, 15, 30, and 60 seconds have passed. These were taken prior to being given each drug and subsequently each hour for 4 hours after administration. After being given psilocybin, they found participants completed and attempted fewer arithmetic and drawing exercises during the first hour post-administration, but after that time, they returned to baseline. Time estimates, however, were not altered. We'll see future studies on this, but typically psilocybin doesn't distort very short-term time estimates, like on the order of seconds or maybe even a minute or two, but distorts perception of time beyond that. In contrast to psilocybin, IT290 produced no differences on any of the tests, whereas JB329 significantly impaired all of the tests, particularly 3 and 4 hours after administration. Although that was the last of the primary outcomes, the researchers were also interested in determining whether you could develop tolerance to JB329. They noted that a prior report showed that tolerance does build in response to the chronic administration of psilocybin, and so they wanted to see if the same was true for JB329. They took a single participant and administered JB329 3 times a day for 22 days, increasing the total daily dose from 0.3 milligrams on day 1 to 20 milligrams on day 22. What they found did support the development of tolerance. Specifically, that after the first few days, the participant's symptoms no longer increased as the dose kept increasing, and eventually, towards the end of the trial, his symptoms began to diminish. So, to wrap up, I'd say that in addition to learning a lot about IT290 and JB329 for the first time, this study also provided a fairly detailed description of the time course of psilocybin utilizing one of the largest sample sizes that we've come across so far, although that's not necessarily saying much. There were a ton of pretty substantial limitations and ethical concerns with this study, but I still feel like we were able to pull some pretty valuable descriptions of the experience of psilocybin. That's it for today's episode. As always, I really hope you enjoyed the show. If you have any questions, feedback, or ideas for the show, please let me know. You can find all of the ways to reach me on the website psilocybology.org, where you can also find the full transcript for each episode if interested. Thank you all for listening, and I'll talk to you next time.